Hello, I'm Dr. Richard Juman, past president of the New York State Psychological Association. I've been a clinical psychologist for many years and I've treated hundreds of patients. But I recently became aware, during a conversation with a trusted colleague, that I really knew very little about suicidality. I realized that I'd been very lucky that over the course of my career, I'd not often been in a position where I needed to respond to suicidality, because I was really not prepared to respond in an optimal way. It also occurred to me that I probably wasn't the only licensed mental health professional who could stand to know a little bit more about suicidality and suicide prevention, specifically how to be prepared for this type of event before you're confronted by it. In many ways, private practitioners are at a disadvantage when it comes to managing suicidality because, as I now know, good suicide care means having a plan that involves a network of people and resources. And clinicians who work in private practice can be pretty isolated from those kinds of supports. So they're at risk for having to deal with a suicide issue on their own and having to determine the best approach in the middle of the crisis. I now know that that scenario, having to figure things out for oneself in the heat of the moment, can be a deadly combination. So who is the trusted colleague that I was speaking with who clued me in about the best practices in suicide care and ultimately led to the creation of this video? It was Dr. John Draper, Director of the National Suicide Prevention Lifeline. I'm pleased to introduce him now.
Hello, my name is Dr. John Draper. I'm the Director of the National Suicide Prevention Lifeline and President of Link to Health Solutions. We're a subsidiary of the Mental Health Association of New York City. I'm also a psychologist with a part-time private practice. As the director of the SAMHSA-funded Lifeline since 2004, I've had the privilege of working with and learning from national and international experts in suicide prevention. Together, we've helped to identify, disseminate, and implement best practices and standards of care for assessing and helping persons at suicide risk. Today, I'm going to talk with you both as a representative of a group of experts in suicide prevention practices, as well as a fellow clinician who has worked with people who are at risk of suicide for the past 25 years. In this brief video, I'm going to introduce you to some concepts and resources that may help you learn more about working with persons that are at suicide risk. This video is intended to be a starting place, a place to begin familiarizing you with where and how you can learn more about best practices in suicide prevention. While working with persons that are suicidal can be remarkably gratifying work, the idea of doing so for many, if not most clinicians, is an idea that is scary and anxiety-provoking. When faced with the prospect of working with a client or patient that is suicidal, many clinicians will question themselves. Am I competent enough to help him or her stay safe? Could I make mistakes in treating them and actually make them more suicidal? And if they kill themselves, could I be blamed for it? Will I be sued and lose my license? What are the facts around malpractice liability and patient suicide? Suicide-related lawsuits against practitioners don't really occur that often, but when they do, they are costly. The Trust Liability Protection Program reports that about 4% of suits against psychologists relate to client suicides or suicide attempts, but they rank second highest in terms of the percentage of total costs paid out. About 17% of lawsuits against psychiatrists relate to post-suicide negligence claims, but they comprise the largest monetary settlements against psychiatrists. Most psychologists and clinicians in general lack adequate training in suicide risk assessment and intervention approaches. A recent behavioral workforce survey undertaken by the Clinical Care and Intervention Task Force of the National Action Alliance for Suicide Prevention reported that less than half of clinicians surveyed reported having the skills, only 39%, or the training, only 44%, or supports, only 30%, that they believe was necessary to assist persons who are suicidal. The best protections for both our clients at risk and our own professional liability turn out to be the same thing. good clinical practice. When clinicians follow systematic, comprehensive approaches that are aligned with the field's standard of care for assessment and treatment of persons at suicide risk, the tragedy of suicide and its ensuing legacy of pain can be avoided. However, sometimes suicides can occur regardless of what clinicians, family, and loved ones do to help prevent it. We cannot always be right, and we do not have the tools to accurately predict whether a person is certain to hurt him or herself or others. Courts recognize this, as noted here. This is from a court decision and a judge statement. He ruled in Stromberg and Dellinger in 1993 that a doctor is not a guarantor of the correctness of his diagnosis. The requirement is merely that he use proper care and skill. The question is not whether the physician made a mistake in diagnosis, but rather whether he failed to conform to the accepted standard of care. When our group asked Skip Simpson, perhaps the country's leading suicide litigator, what he recommends to clinicians in their work with clients who are at risk of killing themselves, he stated this: I would suggest getting away from a concern about liability. If a person is at risk for dying soon, then everything that can be done to save that life must be done. There are no legal consequences to that action. When you're talking about saving someone's life, you forget about confidentiality. As long as you are focused on the mission of preventing suicide, there shouldn't be any liability. Be more concerned about doing your job right based on the clinically reasonable standards of the field. At the end of this video, I will review some specific practices that you can undertake that could be helpful in managing your liability risk. However, the most important thing we can do to protect against liability, that is providing good care and working to effectively reduce suicide risk with our clients, that's what I'm going to be focusing on for the next several minutes with you. In 2010, the National Action Alliance for Suicide Prevention formed the Clinical Care and Intervention Task Force, a group of national experts in suicide prevention in clinical settings. Our job was to review best practices in the field and lay out recommendations for individual and systems changes that could save lives. All of the recommendations in this presentation, they can be found in this document. We strongly recommend that you read this document. It provides essential guidance and evidence-based suicide prevention approaches for both individual practitioners as well as private and public health systems administrators. I will be briefly reviewing 3 areas where clinicians need to be prepared to meet the standards for care of clients who are or could be suicidal. First, risk assessment, identifying severity and nature of suicide risk in clients. Second, intervention and treatment. What can you do to work with your client that will help keep him or her safe? Third, continuing care and shared responsibility. How do you help your client continue to stay connected to care and remain safe between appointments? How can you help keep them safe between seeing you and other clinical or social supports that share responsibility for your client's ongoing care? First, in order to treat persons in our care who are at risk of suicide, we need to be able to identify when they're at risk. We need to ask our clients quite directly if they are thinking about killing themselves. Some people, including some clinicians, believe that by asking a question or questions about suicide to someone, it somehow gives permission for them to kill themselves, perhaps even plants the idea in their head. This, quite simply, is a myth. Prominent suicide prevention researchers from the New York State Psychiatric Institute at Columbia University published findings in an April 2005 issue of the Journal of American Medical Association that exposed this as a myth. Their study surveyed over 2,300 high school students, some of them low risk, and some of them actually high-risk students reporting depressive symptoms, substance use problems, or suicide attempts. The researchers examined the impact of asking students at lower and higher risk questions about suicidal ideation or behavior during a screening program, and specifically whether doing so creates distress or increases suicidal ideation among any of them. Well, Dr. Madeline Gould and her colleagues found that asking such questions neither upset nor increased the suicidality among the students surveyed. For people that are not suicidal, asking the question about suicide, first, does no harm, and second, also gives them permission to talk with you about suicidal thoughts when they emerge. On the other hand, how might people who are thinking about suicide feel about being asked about suicidal thoughts and behaviors? For people who do have suicidal thoughts, many say that they feel relieved that they can talk about it with you. In a Lifeline focus group with suicide attempt survivors, this survivor noted, "If people care enough about me to ask if I'm suicidal and really listen to my answer, I find it a relief to talk about my suicidal feelings. Just because I'm thinking about it doesn't mean I'm going to do it. And if someone just listens to me, that is more of a rescue than calling 911. Keep in mind that every year, 8.5 million adults, 18 and above, have serious suicidal thoughts. And about 1 in 7 high school age adolescents think seriously about suicide annually. However, just over 38,000 persons die by suicide yearly. While it is true that thoughts of suicide were necessarily present in all persons who intended to kill themselves, it is far from true that all thoughts of suicide mean that a person is going to try to kill him or herself. Now, you must always take a person's thoughts of suicide very seriously, because such thoughts, at the very least, indicate the presence of profound and intense psychological pain, which you need to address, whether or not your client actually plans to kill him or herself. In this attempt survivor's message to us, she is making it clear that an important thing we need to be able to do is listen to and empathize with the pain the client is feeling. This is not only critical to connecting with the client, but that empathic connection is also central to gathering more information from them to be able to more accurately assess their risk. If they feel that you understand and care about them, they're a lot more likely to share more information with you. As you listen to your client talk about his or her pain, it is important to ask about and listen for some very basic things that indicate suicide risk. The National Suicide Prevention Lifeline's model for risk assessment identifies 4 basic concepts that indicate suicide risk. These concepts emerged from a consensus agreement among a group of national experts in suicide prevention research and practice, a group that was convened by the Lifeline in 2006. We created a framework for suicide risk assessment for persons in acute crisis, which is now the industry standard among the more than 160 crisis call centers in the National Lifeline network. This framework was published in the June 2007 issue of Suicide and Life-Threatening Behavior, our field's primary journal. These principles provide a simple and elegant framework for conceptualizing whether or not a person might kill him or herself. And these principles underlie all clinical assessments of suicide risk. And here they are. Desire for suicide, that is, I want to kill myself. Intent to die by suicide, I'm going to kill myself. Capability of suicide, I am able to kill myself. And buffers against suicide or reasons for living. The degree to which these factors are substantively present can determine whether or not a person has low, moderate, or severe risk of suicide. As you can see in this slide, which depicts the framework for the National Suicide Prevention Lifeline Suicide Risk Assessment Standards, each of the 4 core principles is comprised of basic components that can help determine whether or not a person is a low, moderate, or severe risk for suicide. If you look under desire to die by suicide, you will see that most of the components related to desire are largely affective. That is, feelings of hopelessness, feelings of psychological pain, feeling alone and trapped, feeling like you're a burden to others. The one cognitive aspect of determining that your client desires to die by suicide is a blatant one, and that is thoughts of suicide. which clearly indicate a desire for suicide. Intent to die by suicide. Take a look at the components under this dimension. Research does indicate that the degree to which a person expresses intent to kill him or herself is the greatest predictor of attempting and/or completing suicide. If somebody says they're going to kill themselves, believe it. Statements or things like preparatory behaviors, gathering pills, acquiring weapons, etc., or making plans to kill themselves, all demonstrate an intent to die by suicide. Capability of dying by suicide. It isn't easy to kill oneself. Typically, it is an acquired capability, something that a person has practiced through past behaviors, or it is the product of poor impulse control that enables capability of killing oneself. And it relates to a number of factors, such as past experience that can serve as a model for future suicidal behavior. That includes such events as past suicide attempts, exposure to suicide, history of violence to self or others. Other factors relating to capability include living in a lethal environment where there is ready access to weapons, pills, or other means people may commonly use to cause harm to themselves. And finally, there are cognitive and affective states that reduce one's ability to control their lethal impulses, such as substance abuse, intoxication, mental illness, agitation, and sleeplessness. These are the kinds of things that can reduce a person's resistance and their impulse control and allow them to be more capable of killing him or herself in the moment. Now, capability, once acquired, especially as it relates to chronic mental illness, past suicide attempts, suicide of a loved one, or a substance abuse disorder, is often fixed. In most cases, once capable, always capable. The most clear indicator of suicide capability is a past suicide attempt or attempts. 7% of all persons who try to kill themselves later do go on to kill themselves. By the way, that's a reminder that 93% of the people who tried to kill themselves went on to live out their lives. Again, demonstration that suicide is preventable. But as I stated previously, a desire to die without intent to die, it's common. I wish I was dead does not mean I'm going to kill myself. But intent to kill oneself is not typically seen without a desire to die. So if I'm going to kill myself, it is typically because I want to die. While reasons for living can affect a person's desire and intent to die, it is also important to note that if all three factors, desire to die, intent to die, capability of killing oneself, if all three of those things are present, that is, your client wants to kill himself, he's intent on killing himself, and he's capable of doing so, that person is a high risk for suicide, plain and simple, regardless of the presence of any buffers. More comprehensive suicide risk assessments may not be appropriate for a number of interviews with clients. Assessments should be a part of how you engage with your client, as opposed to a separate thing you do with them. They need to be woven in and out of your conversation in a way that feels natural. Some basic questions about suicide should be asked, though, of all clients or patients to determine whether they should get more of a comprehensive assessment. The national suicide prevention experts that we've worked with have recommended these three questions, which are referred to as prompt questions for crisis workers. And if anybody says yes to any of these, this would prompt a more extensive assessment. Here they are. Are you thinking about suicide now? Have you thought about it any time in the last 2 weeks? Have you ever attempted suicide? So, is it happening now? How about recently? Have you ever tried to kill yourself? Dr. Sean Shea is a national expert in suicide risk assessment interviews and founder of the Chronological Assessment of Suicide Events, or CASE approach. Dr. Shea's CASE approach is designed to employ practical, effective interviewing techniques to elicit valid information from clients in ways that are engaging, collaborative, and non-threatening. He suggests asking these questions with a gentle assumption that suicide risk is present, which further permits the client for the patient to be fully disclosive about his or her suicidal thoughts, feelings, and behaviors. So notice a subtle difference in how I'm asking the questions now. When was the last time you thought about killing yourself? How many times have you thought about suicide in the last 2 weeks? How many times have you tried to kill yourself in the past? These general assumptions, again, starting with, I think it's probable that you have thought about or tried suicide in the past. Again, open the door for a conversation with a client that suggests it's okay to talk about suicide. A poster designed through suicide prevention experts consulting with the Suicide Prevention Resource Center with the title, "Is Your Patient Suicidal?" was intended to be hung in emergency departments to improve suicidal risk assessment. The poster lists warning signs, common situational factors that are associated with greater risks, and a sample of key assessment questions. Evaluation of the impact of the poster in emergency departments found that it significantly increased clinical assessment of risk in patients seen in these settings. This poster, along with a guide on how to use it in emergency department settings, is available on the SPRC website. It could be a very useful resource for you to have in your office or in your clinic, even though it was primarily designed for emergency department settings. I keep one in my desk. As for more comprehensive risk assessment tools, there is one comprehensive suicide risk assessment instrument that is frequently recommended among my colleagues in the field. The Columbia Suicide Severity Rating Scale, or C-SSRS, was developed through National Institute of Mental Health funds by a team of leading suicide prevention experts at Columbia University's New York State Psychiatric Institute. Its intent is to address a very practical need for summary measures that will help clinicians to assess a full range of suicidal ideation and behavior in a way that is both efficient and comprehensive. Now, data in trials with over 35,000 administrations confirmed that those persons scoring high on prior ideation were 4 to 8 times more likely to report subsequent suicidal behavior. Basically, the C-SSRS appears to be a comprehensive, valid measure for assessing suicidal behavior. The C-SSRS has been implemented in a wide variety of primary care, emergency departments, college campuses, military, first responder, and criminal justice settings. The C-SSRS, like all valid suicide risk assessments, embodies the 4 core elements of risk assessment: desire, intent, capability, and buffers related to dying by suicide. It is divided into 3 major sections. A first section that assesses the presence of suicidal ideation and plans for suicide. A second section that helps you determine how frequent, intense, and controllable the desire for suicide is. And a third section that explores nature and severity of past suicide attempts or behavior. I strongly recommend that you check this instrument out for yourself and consider it for your use. You can learn more about the C-SSRS through a brief online learning module created by the New York State Office of Mental Health, featuring a key author in the development of the C-SSRS, Dr. Kelly Posner, who's from the New York State Psychiatric Institute. How to find that module will be included in the resource list at the end of this video. One of the biggest reasons that clinicians don't ask a question about suicide is they fear opening Pandora's box. They fear that if somebody says yes, they don't really trust their competence and ability to know what to do next. How am I going to keep this person safe? It is likely that the more capable that we feel as clinicians to help a person who has suicidal thoughts, the more likely we are to assess for their suicidality. I'm reminded of an old friend of mine who told me a story about his first field placement in social work as a therapist. He was leaving graduate school, and it was maybe his first week, and one of his first clients came into his office, and the client was in great distress and talked about his long history of mood problems and anxiety problems, a long list of stressful situations, and he was overwhelmed, and he was saying, "I'm going to kill myself." And as he spoke to my friend was listening and thinking to himself, wow, this man is really in bad shape. He sure could use a therapist. Well, there are times when we all feel in over our head, and need to either seek consultation from peers or try to expand our knowledge and skills to help us better address circumstances like a client's suicidality. In this section about intervention and treatment, I'm going to offer a few guiding principles and resources that can help us all feel more capable of helping our clients and our patients who are in pain and thinking of dying by suicide. One thing to remember: the vast majority of research in our field indicates that approaches that show compassion and caring, that help the client feel connected to you and others, are most effective in preventing suicide. While empathy and understanding alone may not be sufficient to keep a person safe when he or she is seriously thinking about suicide, being empathic and understanding are vital ingredients in keeping them safe. Empathy and understanding immediately help a person feel connected with you and can offer some hope and a sense of being valued to persons who otherwise are feeling hopeless and worthless. When your client or patient in some way indicates that he or she is thinking about suicide and he or she is not currently engaged in suicidal behavior, it's important to calm yourself and listen, showing compassion and respect. Many therapists rush to actions that they believe will keep the person safe, such as finding a colleague very quickly or calling 911, or most commonly trying to find ways to talk the client out of killing himself or herself, or by generating suggestions or questions related to reasons for living. Now, these approaches can work against helping you and your client feel connected during a time when feeling connected is most important. I'll talk more about common approaches to developing rapport and connection with clients who are suicidal shortly. Closely related to the maintaining a caring, empathic connection approach is this golden rule: collaboration. It is vital to work with your client to keep him or her safe. In the most comprehensive industry-wide policy for helping callers at imminent risk of suicide, the National Suicide Prevention Lifeline defined this approach as actively engaging persons who are thinking about suicide. This policy, implemented across over 160 crisis centers nationwide, says that we should not only actively listen, but actively engage the individual at risk in a discussion of his or her thoughts of suicide. That means we need to support our clients' experience and how they have taken care of themselves and recovered from hardships in the past. We need to explore their strengths and resources that can help them stay safe now, and help them use their assets to make choices that can empower them to secure their own safety and build hope for their recovery. In a moment, I'll talk more about effective collaborative approaches between clinicians and clients that can help prevent suicide. The third very important area in suicide intervention and treatment that I want to emphasize is this: we need to focus our immediate treatment objectives on reducing their suicide risk and maximizing their safety. Now, that may sound obvious, but it's not what's often done. Typically, a lot of clinicians believe that the best approach to reducing risk in our clients is that we need to more aggressively treat the underlying disorder or problem. Let's make them less depressed or less anxious. So we may focus on getting their antidepressant medication adjusted, or intensively address the relationship problem or work issue that seems to be driving their desperation, or some other mental health problem or life stressor. Now, I'm not saying these things aren't important. They are. You can continue to address those in some way, but they just can't be the primary focus of your care until the client's risk is reduced. Instead, your treatment plan, developed in collaboration with your client at risk, needs to be about supporting coping strategies, thoughts, feelings, and behaviors that promote your client's safety. I'll talk more about suicide prevention specific treatment approaches shortly. There are a number of excellent suicide intervention and prevention training programs that are recommended in the Suicide Prevention Resource Center's Best Practices Registry. That's a resource that will be referred to later in this video. I want to highlight a few approaches in some of those trainings that I think are terrific examples of an empathic, collaborative approach with our clients who have been assessed to be at risk of suicide. One commonly practiced approach is actually evoking and listening empathically to your client's reasons for dying. Now, this is hard for a lot of clinicians to listen to. It can often give rise to your own worries and fears. This approach is emphasized in the widely used suicide prevention training developed by Living Works called the Applied Suicide Intervention and Skills Training, or ASSIST. This approach is based on an evidence-informed assumption that at some level there is a core ambivalence about dying in persons who are suicidal. The desire to die is more so a desire for the intolerable pain to end, which is wrapped up in a more shakable belief that as long as they are alive, they will always feel intolerable pain. But if we try initially to talk people out of feeling suicidal, they're just going to defend or protect that part of them that wants to die, that wants the pain to end. However, if we actually join the person in experiencing their pain around their reasons for dying, through our connection and understanding, they are, paradoxically, more able to access their reasons for living and genuinely engage you in a conversation about living. As the folks at Living Works put it, if you want to help them listen to their life side, show them you understand their death side first. There is much more to the ASSIST training program than this. It is designed to help you explore and factor in your own attitudes about suicide, teach you how to engage and collaborate with your suicidal clients, review their risk, and work together to establish a plan to keep them safe. Another promising practice recommended in the Clinical Care and Intervention Task Force report is the Collaborative Assessment and Management of Suicidality, or CAMS approach. CAMS, developed by the acclaimed suicide prevention researcher and therapist practitioner Dr. David Jobs, is focused essentially on developing a strong therapeutic alliance between the clinician and suicidal patient. It starts with a fundamental philosophical stance that suicidal thoughts are completely understandable, though certainly worrisome, that they're understandable as a response to psychological pain that feels unbearable. Now, from this point of understanding, without judgment or shaming, the clinician can begin to build on this common understanding with their suffering patient and help the client find other safe and effective ways to cope with this psychological pain. Importantly, the CAMS approach treats the patient as the expert on his or her suffering and aligns with the patient to directly address their pain and suffering in ways that promote their safety and well-being. This therapist-patient alliance literally involves the therapist sitting beside the patient in constructing a treatment plan. Dr. Jobs says that CAMS is designed to eliminate suicide as a means of coping, while also helping to increase reasons for living by intentionally engaging the suicidal patient as an active participant in the assessment of their own suicidal risk, and by collaborating with the patient as a co-author of their suicide-specific treatment plan. Another recommended approach that can help reduce risk in suicidal clients is called safety planning. Safety planning is something you necessarily do with your client, not to them or for them. Safety planning is a highly collaborative process where you and your client develop a plan that specifically fits for him or her, where he or she works with you to identify the supports of coping strategies and social supports that he or she believes can help keep them safe. A field-tested and widely used framework for safety planning was developed by researchers at Columbia University's New York State Psychiatric Institute and the University of Pennsylvania, Barbara Stanley and Greg Brown. This framework consists of engaging your suicidal client in the following 6-step process. Using the patient's words, identify with your client the signs that he or she is venturing into vulnerable territory where suicidal thoughts are likely to come up. So first, the warning signs. And secondly, when they do come up, what are some internal coping strategies that your client is willing and able to use when he or she is feeling unsafe? Help them identify thoughts or actions they have taken or they can reasonably undertake that will calm them or distract or support them when they're feeling suicidal. Another step is to identify who they can contact, or places they can go that can take their mind off their distress. Overall, what social activities can distract them? Social supports. The fourth step relates to determining what family or friends they can contact, who they describe as helpful to reach out to when they're under stress. The fifth step refers to helping your client at risk to identify whatever mental health or healthcare professionals he or she can turn to, which should likely include you, as well as others that he or she has trusted in their care. Now, hotlines may also be helpful, but they're a secondary resource to your primary role in their suicide care plan. The fifth step refers to helping your client at risk identify what mental health or healthcare professionals he or she can turn to, which should likely include you, as well as others that he or she has trusted in their care. Now, hotlines can also be helpful, but they're a secondary resource to your primary role in their suicide-safe care. Finally, work with your client to review how to keep his or her environment safe, limiting their access to weapons, pills, or other means for killing themselves. Every practitioner involved in working with a suicidal client must be mindful in assessing for your client's access to lethal means for suicide. Ask about the presence of firearms or pills or any other means that the client has used in the past or has stated that they've thought about using in the past. Another thing I want to note is that a commonly used approach, suicide contracts, it's sometimes confused with this very different approach called safety planning. Well, suicide contracts typically involve a non-binding contract with suicidal clients where the client seemingly agrees with the therapist to not kill him or herself. Well, such contracts are more effective in helping the therapist feel safe as opposed to the client. However, they shouldn't help the therapist feel more comfortable because there's just simply no evidence that they work. On the other hand, the indicators that safety planning are helpful in suicide prevention are much more clear. This safety plan is available on the Suicide Prevention Resource Center website and is the subject of a brief learning module in the Zero Suicide Toolkit, also found on the New York State Office of Mental Health website. That will also be talked about at the end of this video. The safety plan is an important tool for engaging the client in their overall suicide care plan, which should be more comprehensive. Evidence-based treatments beyond psychotropic medications should also be employed wherever possible. In general, more structured, problem-solving approaches have been shown to be most effective in reducing suicidal behaviors in clients that are at risk. The safety plan is an important tool for engaging the client in their overall suicide care plan, which should be more comprehensive. Evidence-based treatments beyond psychotropic medications should also be employed wherever possible. In general, more structured, problem-solving approaches have been shown to be most effective in reducing suicidal behaviors in clients at risk. Dialectical behavioral therapy, or DBT, is the most thoroughly studied and efficacious therapy for reducing suicidal behavior. DBT is designed to teach coping skills to persons who are struggling to manage and regulate unstable moods that can cause great distress, including suicidal thoughts and behaviors. DBT practices have been shown to reduce suicide attempts by half among patients with borderline personality disorder, for example. In addition, similar results have been found for cognitive behavioral therapy, or CBT. CBT has also been found in research to reduce subsequent suicide attempts among a sample of attempt survivors by half. More about these therapies and other best practices approaches can be found in the task force report and in the SPRC website. When your client is suicidal, maintaining opportunities for continuous contact as needed is really important. Clinicians may not only offer more face-to-face sessions per week in these circumstances, but also try a few telephone check-ins as well. Among the most robust findings regarding effective suicide prevention practices relates to continuous contact, connection, or follow-up with persons who are suicidal. Whether the contacts are face-to-face, or they're made by telephone, or by even a caring letter or postcard, the research is clear that for persons who are at higher suicide risk, maintaining contact and connection with them can reduce that risk. Simply, such extra efforts, they convey to clients that you care about them, that you're willing to be there for them when they're in crisis. The New York State Office of Mental Health will also be making available a toolkit on follow-up care for patients that have been recently discharged from emergency departments or inpatient units, persons who are suicidal that have called hotlines, as well as your at-risk clients who need additional support between appointments. Clients who are frequently in crisis, however, may require more team efforts among practitioners, as is often used in clinic settings where DBT is routinely provided. In either case, coordinating care and sharing responsibility for assisting your client in suicidal crisis is very important. Make sure that you are sharing information about your client's risk status, as well as the stressors that affect their situation. You need to share your joint treatment activities and how they're impacting your client's progress. Share all of that with the other behavioral health or healthcare professionals that are involved in your client's care. In addition, seek consultation from other professionals as you need it. Now, if you're a NAASP member, New York State Psychological Association member, you can also contact the NAASP for consultation. It is also important to include family members or significant others in the care of individuals who are at risk wherever you can. As was noted in the safety plan, identifying family and significant others that can be important contacts for the client to help keep him or her safe is critical. However, it will also be important for you to directly include those people wherever you can. To the extent that significant others are just that, significant, which means they care for the person and have an influence on them, they could be instrumental in reinforcing aspects of the SAFE plan, such as helping to maintain a safe environment for them, removing firearms or pills. It could also help provide them with needed support, or drive them to or from appointments, or help look for warning signs and notify you and others if they're in crisis. They can act as buffers for the stressors in your patient or client's life that could worsen the situation, and so on. In addition to your treatment and primary contact information, as well as coordinating your care with other professionals and supports in your client's life, it can also be helpful to provide your client with information about local 24/7 crisis hotlines. It's important that you, in general, learn more about the local crisis services in your area, including crisis hotlines, mobile crisis services, crisis respite services, or other resources that could be helpful for you and your client who may be suicidal. You can get more information about these services through online resource databases and listings, as well as by having a conversation with a staff member at a local crisis or suicide prevention center. Crisis hotlines have been shown through SAMHSA-funded evaluations to be capable of significantly reducing emotional distress and suicidal thoughts in callers. Given the 24/7 availability of services such as the SAMHSA-funded National Suicide Prevention Lifeline, 800-273-TALK or 800-273-8255, they can serve also as an immediate support if your client is not able to reach you in crisis. However, I do want to emphasize, the Lifeline is not a substitute for your care, whether or not their need is after or between your office hours. Your phone number should always be the first one they have and the first one they try to call. A few words about the Lifeline. When callers call 800-273-TALK, they're linked to crisis counselors at the nearest crisis center in the network. And there's about 160 accredited crisis centers in the national network at this time anyway, and there's at least one in every state. Typically, if you're phoning from New York City, for example, you'll get the local New York City Crisis Center, LifeNet. When callers contact the line, they hear a greeting message that prompts them to press 1 if they're a veteran or a member of military service, whereupon their calls are then routed to the Veterans Crisis Line, which is a special service provided by the VA for vets, the military, and the persons who care about them. All centers in the Lifeline network adhere to evidence-informed standards of practice and policies for helping callers at risk of suicide. In 2013, we'll be nearing 1 million calls answered per year. In summary, doing whatever we can to help our clients and keep them safe, in line with generally accepted standards of care, not only offers the best way to prevent suicides among our clients, but taking such approaches are the best way to protect ourselves from malpractice liability. Here I will offer a few more basic steps that can help you manage risk in your practice. The APA Trust suggests that there are 3 areas critical to risk management in your practice. First, informed consent. Second, documentation. And third, consultation. Now, these elements are present throughout these more specific suggestions. First, write out a policy for how you will work with clients who are assessed to have current or past suicidal thoughts. Now, that policy should include how you plan to assess the client regularly, how you're going to collaborate with them, how you're going to collaborate with significant others or family members, as well as how you're going to collaborate with healthcare professionals to ensure their continuous care. It should include information about other emergency or crisis services as well as inpatient settings that are nearby that you may want to engage in the client's care. Suicide-specific treatment planning approaches should also be documented in the policy. Second, your client should be informed of your collaborative approach and desire to seek his or her consent to release information, with the exceptions to confidentiality only relevant to when he or she is in danger and consent can't be obtained. And it's believed that sharing that confidential information is going to be essential to keeping them safe. Number 3, it is vital that you use a systematic approach for risk assessment that is consistent with standards of care for our industry, such as the C-SSRS or the Lifeline Risk Assessment Framework. Documentation about his or her risk status should address the 4 core dimensions of risk identified by the Lifeline: desire for suicide, intent to die, capability of suicide, and reasons for living or dying. Document along those 4 core dimensions about how your client is doing, and that should cover your documentation for them being at risk or not. A comprehensive treatment plan is very important, and that's number 4. And it needs to include objectives specifically designed to reduce the client's suicide risk. It's got to be developed, implemented, and documented. 5, collaboration with the client's family, with the client's consent wherever possible, is really critical. And not only keeping the client safe, but also developing an alliance with persons who will be most affected in the event of suicide. Number 6, consult with other professionals for guidance, for resources or support, or cooperative treatment management with others involved in his or her care. All of these are risk management activities that should be reflected in your documentation as well as your care. There are a number of resources that we can offer to help you obtain more information, materials and skills training opportunities. Shane will mention more of these resources shortly. Overall, it is important to remember that for clients that may be at risk, maintaining a readily available empathic connection is central to everything we do. In addition, collaboration is also essential. Collaboration with a client who will ultimately be responsible for their own safety. Collaboration with other treatment professionals and family or significant others that will have an influence on your client's health, safety, and well-being. Collaboration. Neither you nor your client should have to be alone in addressing suicide risk. Thank you for joining me and hearing about how we can all work together to help make suicide a never event in the lives of our patients and clients.
Hi, I'm Dr. Shane Owens, Chair of the New York State Psychological Association Task Force on Suicide Prevention. Each of us has a role to play in suicide prevention. According to some research, 53% of suicide completers sought mental health care over the course of their lives, and 19% of them pursued this care within 1 month prior to their suicide. The same study found that 45% of completers saw a primary care provider in the month prior to their suicide. As a practicing mental health professional, regardless of the setting in which you practice, you are almost certain to come into contact with a suicidal person. One survey of psychologists in training indicated that 97% of them had contact with at least one suicidal patient, while another survey indicated that 87% of social workers counseled at least one suicidal patient within the last year. More practitioners than you might imagine lose patients to suicide. A survey of psychiatrists and psychiatry residents indicated that half of them lost a patient to suicide. Another similar survey found that the majority of psychiatrists who lose one patient to suicide report losing more than one over the course of their careers. Other research indicates that between 22% and 30% of psychologists and similar numbers of social workers reported treating a patient who completed suicide. The 2012 National Strategy for Suicide Prevention delineates how everyone can and should make suicide prevention their business. As mental health and medical professionals, it is incumbent upon us to provide informed, state-of-the-art, evidence-based treatments to individuals experiencing suicidal thoughts and behaviors. We can accomplish this by seeking the best training, supervision, and consultation available, and by forming partnerships with one another and with other entities involved in the suicide prevention effort. Evidence-based training is available from many sources, including the New York State Office of Mental Health and the American Association of Suicidology. The Suicide Prevention Resource Center keeps a best practices registry of prevention and treatment programs that can be accessed at SPRC.org. NAASP and its Suicide Prevention Task Force stand ready to help you when those under your care experience suicidal crisis. We can be reached via the web at nyspa.org. Further information about both online and in-person training is available from the New York State Office of Mental Health at omh.ny.gov. Help for anyone in immediate suicidal crisis is available at all times through the National Suicide Prevention Lifeline at 1-800-273-8255 or 1-800-273-TALK. Remember, suicide is preventable. One is too many.